Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. Well, it's been almost a fortnight since my last episode, and not that the work world is very busy, but probably like the rest of you, the world has changed. So my desk got relegated to our virtual homeschooling desk, and now I've been able to commandeer that for a day. So I want to get back on and do a few podcasts so we can upload these over the next few weeks. Today I want to talk about a topic which really kind of covers kind of two topics in one. One is basically giving you my kind of interpretation and my career essentially over the past 15 years and things that I've seen change, because we can learn a lot from history, and many of you that are starting out now coming into the total joint world, and things are actually a whole lot simpler and better and easier than they were a while ago. And that's good. I mean, that's what it should do. But the other important aspect of that, what I really want to make sure that you're aware of starting out, is the idea of these improvements are things that you can do for you, for your practice, for your patients, most importantly, and for the hospital. And when you start a new job and a new career, if you go to a hospital where some of these things aren't in place, or as the future unfolds, there are new improvements, you should work extremely closely with your hospital and lay out a gain sharing plan. Basically learning from everything that we haven't done. We and I have made a ton of improvements at our hospital with zero in return for the efforts, aside from asking for more help. I do think it's extremely beneficial because it's improved our patients' care and our patients' lives. However, we have a huge database, all still philanthropically funded. There's really no money that comes to that from the institution itself, where I think it probably should for all the work and efforts that we've put in. So, a lot of the things that I'm going to talk to you about would be things that I would say are really important to set up ahead of time with your hospital and say, hey, if I'm going to come in and work here and I see X, Y, and Z going on, let's make a deal that I'm going to improve these things for the care of my patients. At the end of the day, it's going to save the hospital money, and some percentage thing that pays for your research or pays for funding or covers some extra things that you may want to purchase that help you do all of these things. It's important to kind of have a plan going forward, as opposed to making all these changes and then at the end asking for something in return. So, the biggest thing that I think has changed a lot over when I was in training, 20 something years ago, and now is length of stay. Many of the hospitals that I trained in, it was not uncommon for people to be in the hospital for 5 days, and most of those had a rehab unit attached to it. So it wasn't uncommon to round on the same patient for 2 weeks because they just went from the third floor to the first floor to the rehab unit. We've cut that from 5 days to 3 days to essentially 1 day, whether or not you want to call it 24 hours, overnight, observation. And we haven't gone to the outpatient surgery role or realm for total joint replacements. Why? One, I'm quite comfortable keeping my patients 24 hours. One of the biggest things I think not a lot of people talk about is antibiotics. And, are you comfortable with one dose of pre-op? Do you do a dose before they go home? Do you give them orals? I still like the idea of, doing my one pre-op dose, which we all know scientifically is the most important and commonly used in Europe, but we're still pretty comfortable with 24 hours of IV antibiotics afterwards. There's a big push for many surgeons that have a stake in an outpatient surgery center to do those outpatient joints there. That puts more money in their pocket. But a lot of those people then use that money to buy the resources that then allow you to have a nurse that is calling those patients on a regular basis. How are you doing? What's your wound like? And we don't have those resources. So for me personally, it's a little bit easier to have my patients in the hospital for 24 hours, surgery today, therapy today, see them tomorrow, change the dressing, therapy in the morning, and then home. And to be honest with you, I have very few patients that really ask to go home the day of surgery. If they wanted to, they were young, healthy, low risk, close to the hospital. I have no problems in doing that patient first and doing therapy and getting them home. But it's not something that I'm personally pushing for currently. And, the other big thing with that length of stay, and the thing that I really pushed years ago, which was kind of, I was the black sheep for actually a lot of these things I'm going to talk to you about, which have now become sort of the standard. But, I wanted therapy the day of surgery. Why? Well, I saw these patients that were having surgery, 4 or 5 o'clock in the afternoon and therapy the next morning, and they all did okay. But if I had a 7:30 start time for a case and that patient laid in bed all day for 24 hours, and then didn't get out of bed till sometime later the next day, so over 24 hours of not moving, those patients all did worse. And I thought, why is my 7:30, 9:30 case laying in bed for 24 hours when they could get up and get moving? So therapy was a little taken aback by it. Nursing was a little taken aback by it. And now, like most hospitals, that's standard. What that did in return not only has improved patient care, hard thing to study, but probably decreased DVT rate, decreased aspiration rate, decreased pneumonia rate, again, all things that would have to be studied to make those statements boldly. But most importantly, patients did better. And then they started getting at the hospital sooner. So, I found my length of stay around that time was about 2 days, started same day therapy, and length of stay went to 1 day. And everybody says, hey, I want that too. I want my patients to have therapy the day of surgery, and I want my patients out of the hospital, a day sooner. So that's a big thing. Next thing, venothromboembolic disease. So again, years ago, I remember the book, it was the Coumadin book. Everybody was on warfarin, and you had to go around and check everybody's INR and dose everybody accordingly and make sure they didn't go too high and too low. And being in the hospital, 4 or 5 days, that was your job. And, it was tedious. It was really hard. And, occasionally you went over the limit and those patients bled and had wound complications. And then, we got these factor 10A inhibitors and oxyparin and other medicines like that. And life was great, right? No labs, didn't have to adjust, but then they all had bleeding issues. And now, luckily, aspirin. So, from a hospital standpoint, super, super cheap, compared to warfarin and lab tests or an oxyparin or Fragment or Eliquis, what have you, Xarelto. But aspirin's super cheap. So from a hospital standpoint and a bundle, it's a whole lot less to spend on medications if you're giving people aspirin versus some of these other chemical agents. But, a whole lot easier at the end of the day, one less prescription to write, no lab to follow, but the wounds do look better. So that's been a nice change that for most of you, for your normal risk individuals, probably putting them on aspirin. The high risk individual is different. But that's been a big change that I've seen over the past 15, 20 years. The third thing, blood loss. So it was extremely common to have longer surgeries, more bleeding, more wound complications. Everybody's, hemoglobin tanked, especially if you were doing bilaterals. And I remember being taught early on, bilaterals this morning, check your hemoglobin this afternoon because they probably need a transfusion as opposed to coming in tomorrow and seeing their hemoglobin at 6. And almost everybody auto-donated. I mean, for a while in training, it was normal practice that you would auto-donate, and you just got that back in the recovery room. Nobody even checked an H&H. And we know now that transfusion reactions occurred, risk of infection went up. There's a huge cost to the blood bank. So even when auto-donation wasn't incorporated, you still had bleeding and wound complications, oozing. And then what did you have to do? You got to check at H&H every day. That was a cost. And then they needed a transfusion. Okay, you needed the IV tubing. You needed to type and cross. There's a cost. You need the blood products. There's a cost. Then there's an increased infection risk. There's a potential cost. So all of those things, were issues that cost money. And if you can make changes and save money, you improve patient care, but the hospital's happy because the bean counters see that you've reduced the cost of the total joint replacement because you're not using labs and tubing and blood products. So that's a huge thing. The biggest issue, though, from a patient's perspective is if you're not anemic and you're not stuck in bed getting a transfusion, you feel better. You can do therapy sooner, which improves your outcome. We saw with the advent of TXA, our transfusion rate was around 20%, and now less than 1%. So that one little addition of this nice generic drug has made this huge improvement. But obviously, if you were going into practice in a hospital that wasn't standard, that's easy pickings. You say, hey, listen, I'm going to introduce this generic drug that's really cheap, and I'm going to reduce our transfusion rate across the hospital, across the institution, and has all those secondary benefits. Anesthesia. So, places where I was trained, it wasn't uncommon general or spinal or epidural. You had, indwelling catheter, single shot. I mean, we did all those things. And where I am now, the biggest issue that we had with the spinal epidural world, was initially, most patients were on Lovenox. So that was an issue with indwelling catheters. But, it was very operator dependent on the anesthesiologist. And then, what did they give them? What was the combination? And the problem on the floor was they were over medicated, over sedated, pruritus, and you're dealing with potentially more narcotic than they needed, or more anesthetic than they needed, and they were weak and had a Foley catheter and couldn't do therapy. And lo and behold, they would call the anesthesia team, may not get in touch with the doc that gave it. And at the end of the day, I'm the person that has to deal with the patient and the family. So they're upset because they were in pain or they had side effects, and, it lost control. So, and then we have issues on which floors can have the pumps if you have an indwelling catheter, and so there's a lot of variables in my own particular practice that made me want to transition to simply using just a regional block on the affected leg and general anesthesia. Again, although we're not going to debate the issue in this talk about all the positives and benefits and negatives and pros and cons of general versus regional, but when we started doing blocks, the femoral sciatic was great for pain control. I mean, patients had no pain whatsoever. Problem is the perineal division of the sciatic, densely innervated. So when you had a valgus knee and a sciatic block and they had a foot drop for 48 hours, was it you? Was it the surgery? Was it the block? So that was a little nerve-wracking. But we also had such good dense blocks with the femoral that they couldn't do therapy. So now we have knee immobilizers on every patient, which is around $150. So every total joint, there's an extra $150 charge for a knee immobilizer they use for 24 hours. They couldn't walk because they had a foot drop, so they were in the hospital an extra day. And then they had this huge rebound effect because when we started doing those, it wasn't normal to use scheduled non-narcotic medication. So there's a whole lot of issues there. Now, us, like most people, using an adductor block. Why? You don't get the foot drop. You don't get the sciatic. You get decent enough pain control. You don't get the muscle weakness that you got from the femoral block. There's no need for a knee immobilizer, so they can get up and do physical therapy. So that was a huge benefit. So that's been really, really helpful for me. And then I still have control over their pain management with an intra-articular block plus the scheduled, non-narcotic around-the-clock oral medications. So next thing, infections, nasal swab. I remember reading the study at Pittsburgh and, looking at their infection rate was actually quite high, and they did the nasal swab study and thought, hey, this is a cool idea. Our infection rate was always quite low, but when we started doing the nasal swab study, what we found at least is we were able to identify who was a MRSA carrier and give the appropriate Vanco antibiotic to those individuals. So when we looked at the cost analysis, I would say that if you're at a hospital where Vanco is prevalent and everybody did get, or rather MRSA is prevalent and Vanco is given to everybody, I don't believe that the nasal swab is necessarily worthwhile in that setting. I would just treat everybody nasally with mupirocin. And if you're giving everybody Vanco and Ancef, so be it. However, in our institution, Vanco was not super prevalent. So if people were only getting Ancef, we wanted to capture who was potentially at risk of a MRSA infection. And although not statistically significant when we did our study, what we did find is we could capture the MRSA patients, give them Vanco. And in that group, we had no MRSA infections, which was, in my opinion, a benefit. So again, the nasal swab study, allows you to identify MSSA and MRSA patients, decolonize them, give the appropriate antibiotics to MRSA positive patients. And again, if you are at a hospital where the infection rate is high and you can introduce the nasal swab protocol and you reduce infection risk in your hospital, that becomes something to discuss with your hospital management ahead of time and work out some gain sharing program that you can do to improve the care at your hospital. What about Foleys? So for most places, you probably don't see Foleys. Foley catheters were the norm. That was common. So everybody got a Foley in the operating room, and then it was in for 24, 48 hours. What did I not like about this? Well, the one thing is that patients didn't get out of bed because you had a catheter. So if you had a catheter, there's no reason to get out of bed and go to the bathroom because you just peed into the catheter. And patients were in bed for 24 hours. Again, going back many, many years, they didn't do therapy the day of surgery. So then they would come out the following day. And more commonly in men than women, you would take it out, and now they would have urinary retention because you irritated their urethra. So what would happen? Foley catheter goes back in, and it comes out again, and it goes back in. And, we have our protocol that if that occurs, it goes in, stays in, they get a leg bag, they go home, they follow up in urology. But, you're having all these issues with urinary retention. And then UTIs, you're instrumenting the bladder. So you were increasing the chance of a UTI. And we had a number of UTIs in our setting. So for me, the big issue when I stopped using the catheters was really kind of, when I started having patients up with physical therapy the day of surgery. And, what I would have from a lot of these patients is they would complain, hey, listen, I got up with physical therapy. I felt really good, but I had this stupid bag I had to, attached to my walker and walk up and down the hallway with it. And it made me think, really, the surgeries aren't that long for a primary. So we don't need the Foley catheter for the duration of the surgery. And they're getting out of bed the day of surgery. And we're worried about UTIs. Are we worried about retention in men? I wasn't sure. So we started pulling the catheters. And around that time, there was some questionable data on whether or not Flomax, was useful, something I added in. But what was interesting and what I found was that, there were some patients that post-op had urinary retention. Usually you could predict it. They had pain. They had a little bit more narcotic than most. They had anesthesia. And it was a guy that usually had some prostate issues. But what was interesting is I had less urinary retention when I stopped using Foley catheters than when I was using them because you weren't instrumenting the bladder. And at that point, UTIs essentially disappeared because we weren't instrumenting bladders. And again, this became another cost, about $150 for every Foley catheter. You look at over 2,000 total joints in an institution, along with replacing it for those that have urinary retention and along with treating UTIs. That's a big cost. So if your hospital is still using Foley catheters, again, another issue to improve patient care and outcomes, but at the same time, work with your hospital on gain sharing options. So what about routine labs, right? You come into round in the morning, lab's already been in, patient's been awake, they've been stuck to do what? What are you looking for? So if the transfusion rates were 20%, we were always worried about their H&H. And when we were using Lovenox, we were worried about platelets. And what I'll talk about, shortly too is IV fluids. When we gave tons of IV fluids, we were worried about hyponatremia and hypokalemia. So all of a sudden, we're not doing fluids, we're not doing Foley catheters, we're not bleeding. What are we looking for? So, I slowly started eliminating patients that aren't anemic ahead of time. I'm not really worried about their hemoglobin. Why? Because we gave them TXA and their blood pressure's fine. So now, I even went prior to that from CBCs to H&Hs because they're about a third of the cost. So again, if you're not looking at platelets because you're not using Lovenox, you're not looking at white blood cell count because there's probably leukocytosis, and you're only worried about the hemoglobin and hematocrit, why do the CBC? It's a lot more expensive to do the H&H. Save your hospital money. Gain sharing. And then if you're not bleeding and you start to look at 50 H&Hs and they're all within normal range, why are you doing the lab? Why are you sticking your patient? Why are you wasting the time to look at the lab? So for me now, that if I have a patient post-op that's a little hypotensive, give them a bolus. Still hypotensive? Check an H&H. Or somebody that's anemic, or there's some medical condition that may increase the risk of bleeding, check an H&H. But routinely, why? And the same thing with the chemistries. Normal kidney function,
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
What are you looking for? History of renal insufficiency, renal disease, maybe a diabetic, maybe a person that is at risk of, hypokalemia, hyponatremia due to diuretics or diabetics. You're worried about ileus. There may be a reason, but have a reason for ordering that test. Again, waste of money if you don't need it. You're sticking the patient, and what do you do with the information? So the idea of routine labs, and you might say, hey, we have this protocol that for these patients we order them, and for everybody else we don't. Again, gain sharing, improving patient outcomes, improving care, but have a reason for what you're doing. And then routine IV fluids. So, again, I think a lot of hospitals, they don't always want patients to know, there was a big push a while back when IV narcotics were short. So there was, protocols around hospitals of, teaching nursing staffs like, hey, what to tell patients as far as we're going to use the oral medications to improve your care and this and that and the other thing. And in reality, hospitals were short on IV narcotics. And we saw a shortage of IV fluids when the hurricanes hit Puerto Rico a few years ago. I didn't know at the time, but a lot of those IV fluid bags were actually made in Puerto Rico. And since they were short, big protocols came out. Hey, limit your use of IV fluids to only necessary patients or, a liter, and then reassess. And it got me thinking, my patients are eating. They're not NPO. When we're giving IV fluids, we were inducing a lot of times hyponatremia, hypokalemia. They had to get up and go to the bathroom. So I stopped giving IV fluids. Why? Didn't need it. They were eating. Now, who do you give it to? Well, if you have somebody that renal insufficiency, maybe someone late in the day that's, that looks dry, maybe NPO for a little bit longer than normal. Maybe it's a diabetic. So there may be instances where you need to give routine IV fluids. But not on everybody. Why? Because they're eating. And again, if you're pushing to outpatient surgery, nobody goes home with an IV bag. So again, saving costs, saving money. And the other thing, which I think is pretty much the standard now, but I remember when I started, people weren't as interested in smokers. They weren't as interested in obesity. They weren't as interested in diabetes. I mean, we knew about it. We knew that was risk. But now there are many more protocols in place of optimizing somebody's diabetes, optimizing somebody's weight, getting them to quit smoking. I mean, the list goes on and on. Nutrition and hypoalbuminemia, all of those things we're doing on the front end. And at the end of the day, this has led to better outcomes, less complications. Again, less cost to the healthcare system because you're improving patients' care. So if you don't have a protocol in place at the hospital that you're going to, sit down and go, hey, listen, I'm going to write all this out. All of the docs that are doing total joints should be doing X, Y, Z. And I can show that if we follow this data, that we're going to improve outcomes and reduce complication rates. And the other thing, and kind of the last thing, which is the big money thing, is implants. So, it's a weird, funny world that we play in. I am not in agreement that, these are all wheeled and dealed, and I'm not part of those decisions and discussions, at our hospital. But every hospital has these discussions between groups and boards and committees on, company A is going to charge us this much, and company B is going to charge us this much, and they're going to upcharge for this special product, and we're going to set a contracted rate for this amount of dollars for a total joint, and any company that can meet it can play the game. And honestly, you hear about the variation of thousands and thousands of dollars, between healthcare systems that they're paying for the same implant. Why isn't it more transparent? Why doesn't someone come out and go, listen, hey, this is the cost of total knees and total hips for standard implants, standard bearings across the health systems, across the United States. Let's cut healthcare costs. There's no reason that you should pay $3,000 for a total knee and your hospital should pay $8,000. Now, there is some volume discount things there. So I would say that if you were making it transparent, you would say, okay, if your hospital does X number of total joints per year, this is the cost. If it does this much, it's this cost. And if it does this maximum or anything over, this is the lowest cost bundle that we give you. Because, there's an issue that if you do a few total joints and every single time the company's got to send over all the instruments and send over all the implants, there's some cost involved. But if you're a high volume center and, your center has 4, 5, 6 trays of instruments there, the company never has to send them back and forth. The hospital takes care of them. And the implants live there. You got 3 of every size, and just every so often courier comes over and restocks. There's pretty low cost to the vendor. And the doctor and the hospital are making them a ton of money. So they should have a lower cost than if you're doing, less than 50 a year. But you need to know what your hospital's paying for each company. And you also need to know, what the contracts say. I remember at one point that one company came out with, large heads and they were trying to upcharge that it's not fancy. It's a bigger diameter. It's the same material. That's not some super new technology. So they shouldn't be paying extra money for that, new big head technology. Dual mobility. Okay. Then you're talking about more parts and you could maybe make an argument, but you want to set some parameters. This is a total knee. This is a total hip. This is the upcharges if we choose to add it, but then be selective. You may have doctors in your institution that are putting high-end, very expensive implants in older, low-demand patients. Well, why? So if you set parameters and say, patients over this age can get this, patients under this age can get this, so you're setting parameters, you then can control the overutilization of technology that's not necessary. If you have a particular surgeon or surgeons that do that, saves the hospital money. But also if you're up front and have some control over the volume, then you can work to reduce the costs of the implants. And again, in a bundled care setting, you're going to save the hospital money. So it's a lot of information. And, again, some of that, I think if you're a PGY 1, 2, even 3, this may be overwhelming. If you're a PGY 5 fellow, really, really important information to think about when you go into practice at the hospital that you're going into, of having a list of, what you've been trained to do and what you've seen and what you've read and what's currently going on at your hospital, and starting to make a list of what you can do to improve it, but then set this up ahead of time with some gain sharing model that benefits you for all the work that you're going to do, and having a way to monitor it and record and, track these changes. For those of you that are younger, just understand that what you see now is not what it was 5, 10, 15, 20 years ago. And in a lot of ways, your life has gotten a whole lot easier, because length of stay is short. You're not rounding on these patients, day after day after day. They're getting out of the hospital sooner. They've lowered the risk of venothromboembolic disease. Blood loss is cut down. Transfusion rates are almost non-existent for routine primaries. The pain management blocks. Nasal swabs, you're identifying patients that are carriers and treating them a little bit more aggressively, eliminating Foley catheters, eliminating labs, eliminating IV fluids, and you're just optimizing patients that are having better recoveries. Now, whether or not you choose to do this in a hospital setting in a 24-hour observation model, or as an outpatient from the hospital or outpatient from the surgery center, that's a whole different discussion. And there's just some different issues that are involved there. But this at least gets you thinking. 10, big bullet points on things that you can work on, and things that you should look at if your hospital is not already doing these things. And you may, have some other ideas that I didn't even mention. So, if you have something new, interesting, exciting, put it in the comments, share it, with your colleagues, and use all of this, again, for the most important reason: to improve the outcome of your patient. That's the whole reason we went into this. So I hope you found this episode interesting. More episodes to come. Again, if you're enjoying what you're hearing, please leave a review. That helps other people like you find this podcast. And if you have other friends, residents, colleagues that you think would benefit, please send them a link, share this with them. And until next time, stay safe. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.